work being done there by introducing assisted dying. So I've looked after people dying in war zones when I was in the military, in NHS wards, and in an Ebola hospital in Sierra Leone in West Africa when they had their outbreak there. And now I'm looking after dying people in our local hospice. And everywhere, their needs are the same. And they're best understood by having a look at what goes on, I think, in hospices and palliative care generally. And tonight, as we go through, there will be a few statistics, but not too many, I hope. There'll be a few emotive topics, but I'll try to keep it all fairly bearable. And what I'm going to do is focus on the rational and ethical arguments about assisted dying. Of course, church teaching is extremely important for Christians who are here tonight, and there may be a chance to touch on some of that afterwards in the discussion. But to set the scene, I'd like to tell you about Consuela. She was one of our patients. She was a lovely lady, but very, very troubled. She came from overseas and she had advanced breast cancer. And she'd had several years of intensive treatment with surgery, chemotherapy, radiotherapy, and initially had got a bit better, but then her cancer had spread, and now it's in her bones and it was in her liver. And as well as that, she had really quite complex social circumstances. She'd been married several times, and she'd had several abusive relationships. And a recent family suicide had happened, and that caused a real crisis. And although she was on our hospice books, she kept herself at arm's length from us, really, because she didn't like the association of being attached to a hospice. But her GP asked us to increase our contact because her symptoms were getting worse. She was losing some weight, she was in pain, and she had infected sores appearing on her arm. These had swollen up enormously due to cancer in what we call the lymph channels, which take fluid away from the limbs. And she found this horrific. She couldn't even look at her arm. So one of our specialist nurses from the hospice visited her and got Consuela to come in. She was reluctant, but she came in for a symptom control admission. So we're going to try and sort out the sores and sort out the severe bone pain. And she was in a very bad place, physically, emotionally, spiritually. She'd had enough. She wanted to die. She was really suffering in so many ways. And when she arrived, she really was quite dismissive of our help. And she spent nearly all day in bed. What she asked for, in fact, was something to end it all. She wanted to be alone. But then after a few days of listening to her, showing we understood, explaining her symptoms, explaining how we could relieve them, and getting her to believe she had some living left to do, we were able to relieve a lot of her pain and anguish. And it was really down to our fantastic nurses in the hospice. They made it possible because they're experts at breaking down barriers and getting close to patients. So Consuela then was able to sit up a bit and start talking to people and laughing again with staff and with family. And she started going to the art classes and the alternative therapy spa treatments that we have in our day hospice. You'll hear about the day hospice in a minute. But after 2 weeks, she managed to go home for a day and then for longer periods. And she was eventually able to stay at home for a fortnight with visits from her overseas relatives. She was supported during that period by our hospice nurses at home and our family support team, which has counsellors, social workers, and our chaplain. And then one night, a week or so later, she suddenly became a lot weaker. So she had to come back to the hospice then. She was able to smile at the staff looking after her and then quietly sharing a few words. But then she died peacefully that very night with her physical symptoms and her spiritual distress really under control. So if you address the fears, treat symptoms as best you can, but most importantly, accompany the suffering person, you can achieve wonders in palliative medicine. So this is where we're going to go over the next half hour or so. We'll take a dive into palliative care, first of all. What is it? Where is it delivered? How it's delivered, the problems it's facing at the moment, and hopefully debunk some of the myths about it as well. And then we'll move on to assisted dying, what that is, how it's delivered around the world, some arguments for it and against it, and its potential impacts here in the UK. And as we travel down this road that you see on the slide, we'll see it's the opposite of effective, compassionate end-of-life care. So starting with the palliative care approach, this lovely lady is Dame Cicely Saunders. She put palliative care and hospice medicine on a modern scientific footing. And we think of her as the founding mother of our specialty. She first worked in this field at St. Joseph's Hospice in Hackney, which is run by the Sisters of Charity and is still going strong today. So her great quotation here on the slide captures the ethos of palliative care and all good end-of-life care, really. So you matter because you are you. You matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die. So you can see it's completely patient-centered, it's hopeful, and it affirms the true dignity of life. And the World Health Organization itself recognizes these 9 elements of good palliative care. You can see on this slide. I won't go into them in depth, but you'll see they embrace the whole person, their physical symptoms, but also their psychological and spiritual distress. And it supports both the patient and the loved ones. And most importantly, palliative care affirms life, while accepting at the same time dying is inevitable. But it's emphatically not about hastening that death. And especially in hospices, it relies on really great teamwork. So in relation to dying, dignity is talked about a lot. And assisted dying activists will claim it's really the same thing as autonomy, really have the ability to make a choice about your own care and things. And they say that this autonomy gives you a right, therefore, to assisted dying. In palliative care, generally, we take a very different view. We see dignity as something inherent in every human being. It's the same concept of dignity that you'll see in the paper that's just come out of the Vatican at the end of last year, called Dignitas Infinita. And that sees this inherent human dignity as coming out of man being made in the image of God. And it's reflected by this similar concept, which is found in the Universal Declaration of Human Rights here in this slide. It requires us to recognize the other for who they are, to be present for them, and to recognize their worth. And it really emphasizes the value of human life. So compassion is also fundamental to good healthcare. It involves both suffering with the other person, but also taking the next step, acting to relieve their distress, as in the Gospel's Good Samaritan here in the slide. It's very different from the false compassion used to argue for accelerated dying for those suffering. That solves the demand to share the pain by ducking the issue, by ending the life. It sends a clear message that the life is not worth living. You'll often hear, for example, you wouldn't let a dog suffer like that. That kind of mentality abandons patients. It's the opposite of our palliative care approach, with compassion and being present for the sufferer. This is the right way to act, I think, in the beliefs of Christians and Muslims and many other people as well, some of them who don't have any faith at all. So what about hospices? In the UK, a lot of palliative care is based in hospices. These are really centres of excellence for the care of the dying and the terminally ill. And people are often under the care of the hospice for months or years. Sometimes, though, it's just a few days or hours. And they generally have these 3 components that you can see in the slide. They have an inpatient unit, they have a community service, and they have a day hospice. The inpatient unit is what people think of when they hear the word hospice. And it's sort of halfway between a hospital single room and the patient's home. But it's much more like the best hotel room you've ever seen. And people come in for 2 reasons. Firstly, to control difficult symptoms, such as pain, anxiety, or shortness of breath. And secondly, they come in for end-of-life care, if hospice is where they want to be when they die. Of course, people often move between those 2 groups as their illness progresses, and sometimes they come in and out of a hospice several times. But note, around half of those who come in go home again. It's not a one-way ticket. That's one of the misconceptions about hospice care. So the second component is the community team, and that's got 2 main services. It has the nurse specialists, which we call clinical nurse specialists, who are very experienced senior nurses. They've often been ward sisters beforehand, senior nurse managers, but they're also prescribers, and they can prescribe medications for people. They support people at home. They also liaise with the other services they need, often over quite a long period in the last few months of their life. And then we have hospice at home as part of the community team. And these are more hands-on nurses and care assistants who provide care during the last short days of life, allowing patients to stay at home if that's where they wish to be when they die. And then the third component is the day hospice in the middle on the slide. That's got a clinic. It's got physio-led breathlessness and exercise classes. There's counselling, and there's complementary therapy, and there are art and music classes, things like that. So sorry, it's time for a few statistics now. So there are around 2/3 deaths per year in the United Kingdom, and half of those take place at home or in care or nursing homes, and about 6% in hospices, and the rest are in hospital. Increasingly, hospitals do have palliative care teams, but they're still not as full provision as they should be. It's usually not a 24-hour-a-day, 7-day-a-week service. But it's important to remember, though, for those people who are dying at home or in care homes, they are also often under their local hospice through the community teams we talked about. The community teams will visit and advise the family and the professional carers looking after the patient and link them into the hospice specialists. And when people are asked, most of them don't want to die in hospital. They want to be at home or in the hospice. Now, funding of hospices and palliative care generally is hugely important to this discussion, both because of its effects on the availability of the care for the suffering people, but also, and perhaps most importantly, because it's at the centre of the assisted dying debate. And currently in the UK, we have around 200 hospices caring for around 300,000 people per year. The quality of that care is internationally recognised to be the best in the world, but it's severely underfunded, and it can only survive through charity and fundraising. On average, the NHS only meets around a third of hospice costs, and smaller hospices get even less. So as a result of that, around 100,000 people die without the good palliative care they need each year in the UK. That's 1 in 4 of those who need palliative care at the end of their lives. Just think about that. It's clearly terrible for those people. It's also terrible for their relatives, and it's terrible for society. Such bad deaths make assisting dying seem more attractive. And a parliamentary report just the week before last, I think, has also condemned the current way of funding hospices as not being fit for purpose. It's completely inequitable. It's unfair. Annual spending varies between around £10.33 to just 23 pence per person across the country, depending where you live. And of course, our population is getting older and demands will keep going up. We know that the number of people dying in the UK will increase by around 25% over the next 25 years. But despite all this, the NHS providers provide lower funding increases for hospices than for other services. And because of all this financial chaos, hospices around the country are having to reduce their services and making staff redundant. And this is going to lead to people dying in avoidable pain, as you can see in this report from the Guardian newspaper a while ago now. And this leads in turn to pressure for assisted dying. So a little bit more statistics for a second or two. So where assisted dying has been legalized already, there's evidence it's bad for end-of-life care. So this is a study of European countries, and it shows that any increase in palliative care spending between 2005 and 2019, any increase in spending was much lower in the countries which allow assisted dying than those countries which do not allow it. And it's true for hospice care, palliative care in hospitals, and palliative care in the community. So if you compare the 3 blue columns, which represent countries where assisted dying is not allowed, with the 3 grey columns, where it is allowed, for each of those 3 settings, you can see great differences in the increase between the 2 groups of countries. And there's more evidence. This slide here compares data about the quality of end-of-life care the quality rather than the amount spent across the world. And it shows how things change between two reports, one in 2015 and one in 2021. And it's very telling. The three places with the best provision, the best quality of palliative care, which included the UK, did not have assisted dying. Only one out of the top 10 ones has in fact legalized it. That's Australia, and that's dropped in the rankings since it introduced it. And as you'll see, most of the other countries that have got assisted dying, as we'll see when we come to discuss it around the world in a second, most of those places, it's fallen their place in the rankings over that period, often by very many places. In Canada, things are so bad now that the authorities in Vancouver, for example, have stopped funding a hospice there because it refused to undertake assisted dying. So please don't believe those who claim that palliative care isn't adversely affected when assisted dying is legalized. It is. And when you're writing to your MPs, you can bring this information into your letter if you like. And then moving on to the NHS more generally, we know that that is in crisis. It nearly always is in crisis, as this headline from what Wes Streeting has been saying illustrates. And the recent Darcy report, Lord Darcy is a senior lord. He was a surgeon in cancer surgery, I think, originally, but now his main job is reporting on investigating the National Health Service. He was initially appointed by the government as the cancer SAR about 10 years ago. Anyway, he's written a report about how bad things are in the NHS now. The ones on that column on the right there are the ones that are probably most relevant for the assisted dying debate. I'll just flag up a couple of them. So we have the huge increases in the number of patients per GP around the country, and also the fact that more than 2 million people are waiting for community services or mental health appointments. And the danger is these shortfalls could make people feel assisted dying is the only way out. And people are suspicious now that assisted dying is really about cutting costs. And that's why it's being debated in Parliament and may end up being introduced if we don't get on and stop it. And perhaps that's not unreasonable. In 2017, there were economists in Canada wrote a paper that showed assisted dying would provide health budget savings of $139 million per year compared with normal care. And this will increase greatly as eligibility for assisted dying is broadened, as we'll talk about in a minute. There's a professor called Mark Glazer, who's a UK cancer specialist, who recently went public about all this. He said, if assisted dying is legalised, it will create a culture of hopelessness in the NHS. It will be a disaster for patients. But he added, it might be good for the NHS budget. So what about assisted dying? Focusing in on that for a bit. So I'll use these definitions. They're from the government website, but it's important to realise all these terms are contested and language is very important in this area. Firstly, there's what's called assisted dying, and this is an umbrella term that includes euthanasia and physician-assisted suicide. Euthanasia means healthcare professionals administering lethal drugs to their patient, and assisted suicide is healthcare professionals prescribing lethal drugs for their patients to take themselves. There are other euphemisms used around the world. In Canada, it's called MAID, MAID, Medical Assistance in Dying. And in Australia, it's called VAD, Voluntary Assistance in Dying. And like the term assisted dying itself, these are all used to avoid the negative connotations. But in reality, they're all situations where health staff, usually doctors, either help people to kill themselves or directly end the lives of their patients. And morally, there's no difference. And what's happening around the world now? Well, so far it's legal in a handful of mainly rich, developed countries in Europe, North America, and the Commonwealth. In some places, it's assisted suicide alone that's allowed. In others, it's both assisted suicide and euthanasia. And assisted dying champions around highlight that these 350 million people around the world who have access to it, this is great progress. But actually, if you remember, there are 8 billion people in the world, so only 1 in 25 can legally have their lives shortened by their doctors like this. And there are 195 countries in the world. So these few, 13 or 14, depending which figures you use, very few permit it. And if we maintain the status quo in this country, we'll be in very good company with most of the world's people and most of the world's countries as well. And what about the UK? So the first foot on the ladder that assisted dying activists want is to get assisted suicide made legal for the terminally ill alone. At the moment, they're not mentioning euthanasia. At the moment, they're not mentioning people who haven't got a terminal disease. But let's see what happens. At present, assisting somebody to commit suicide is illegal under the 1961 Suicide Act. But hardly anyone goes to jail for that. There have only been 4 convictions, 4 in the last 15 years. And euthanasia itself is considered murder in Britain. So removing these legal safeguards is very dangerous. There have been lots of attempts to legalise assisted dying here in the UK over the years. They always say that surveys and opinion polls show people seem to want it, and that's why it should be allowed. We'll come back to that in a minute. And now we've got this new bill in Parliament. That means legalisation is beginning to look dangerously possible. In public, the people who want to legalise assisted dying tend to use autonomy, that's choice, and a wish to relieve suffering as their main arguments. But in the media and in their campaign materials, statistics are often misused, and there's often misrepresentation, perhaps it's misunderstanding more than misrepresentation, about what good end-of-life care is, about how effective it is, and conversely, about the really serious problems where assisted dying is already legal, such as Oregon, which we'll focus on in a moment. Oregon is the kind of legalized assisted dying that the British supporters of it would like to bring in here. We'll touch on some of these problems as we move through the talk, so keep listening. But firstly, what about those polls which seem to show apparent public support for assisted dying? Well, firstly, there are big problems with how they're conducted. Firstly, generally they're online, selecting from panels of people who signed up for the surveys, often for a payment or another emolument of some sort. People who like doing surveys. Clearly, this disadvantages those who haven't got a computer, haven't got internet access, the illiterate, those with visual impairment or mental disabilities. They can't take part in surveys very easily. The very people, however, who are likely to be impacted by assisted dying. And it excludes those most likely to be affected, the terminally ill. And it also misses the views of another main stakeholder in all this, health professionals, the ones who are going to have to perform the dreadful act if it becomes legal. Both groups have far too much to do to bother with surveys. And secondly, there are big problems with survey design and the way questions are worded. For example, one study looking into this asked, do you support the idea of euthanasia? And 79% of people who were asked said yes. But when they asked the same people, do you believe a doctor should be able to deliberately bring about a patient's death? Only 30% or so of the same people said yes. So it's all about how you ask the question. And that overlaps with a third problem. So people don't understand the terms properly. Asked, do you support assisted dying being made legal? They think it includes allowing do not resuscitate orders or withdrawing burdensome treatment. And both of those are legal in the UK and they're not part of assisted dying. Some people even think it means having good palliative care while you're dying. That's clearly, as we've discussed, the opposite of shortening life by assisted suicide. And finally, as assisted dying becomes more topical in the press and on TV, and coming up in the run-up to the bill being debated in a couple of weeks in Parliament, people learn more and more about what's at stake and about the concerns of doctors and other experts. So in Scotland, where their bill is a little bit further along than ours is, numbers who are strongly in favour of assisted dying are falling in the polls as more people hear how doctors and lawyers think it's not a good idea. And last week's Observer, which some of you will have seen, had this article on palliative care doctors here, highlighting the dangers of assisted dying if it were introduced. when there's such under provision and underfunding of care as we've just talked about. And hopefully, warnings like this will make lawmakers think twice. But we have to have these warnings made often and repeated to the lawmakers, which is why it's important that you all write to your MPs, as you'll hear over and over again tonight. Sorry, I've gone too fast there. It does seem that the views of the public are indeed changing. Dignity in Dying, the people who are sort of trying to bring in assisted dying in the UK, their own poll recently showed that overall only 43% of people want their MP to vote for assisted dying. And among Black and Asian voters, it's only 24%. And among faith groups, support was the lowest among Muslims at only around 19%. All the Christians were lumped together, I think, in this survey. But it was also low in the 18 to 34 age group. And among the regions, it was lowest in London. So you can see the public are now getting very cautious and less supportive. And Parliament arguably should take note of this. This is what I told the MPs when I was talking to them in Parliament a couple of days ago. Now, moving on to people's reasons for requesting hastened death for themselves, these are very different from the arguments that people use for legalizing it. And these reasons are consistent in different countries. We've had reports from Canada and from Oregon, and we find that these reasons are usually due to what's called existential suffering. And that includes things like loss of dignity, loss of control, or fear of dying itself, or fear of unpleasant symptoms in the future, but not by uncontrolled actual symptoms of pain, things like that, at the time the request is made. And in Oregon, nearly 50% of people give their reason as being a burden, feeling a burden to other people. And over 8% cite financial concerns as the reason. Both of those are really red flags for coercion and inequality. And clearly, assisted dying doesn't do anything really to help this sort of suffering or these sort of fears. But also, sadly, these requests show that people don't know how effective good palliative care is and how it's going to help them. And that's why they have these existential concerns. And we do have techniques to address that sort of suffering. We explore what's important to patients in their lives and their understanding of their own dignity, their worth, what they've done with their lives, and about their fears, and then to address those things. And this is called dignity therapy in palliative medicine. It's part of listening to and accompanying the patients. And it lets them realize their life does still have worth. It's still worth living. There are two more things that are important in this connection: depression and hopelessness. And both of those make it more likely that terminally ill people will ask for a hastened death. In one study, 1 in 4 terminally ill people with these wanted a hastened death. For those with both, it was 2/3. But we know that depression is common in the terminally ill, around 50% of people. But we do also know that it's often missed. It's often not picked up. But it's both more likely to be present if someone's suffering and is also itself a cause of intense suffering and distress. But it's treatable. And even more importantly, if it's not treated, it impairs your ability to make sensible decisions, such as decisions about whether to request assisted dying, for example. And we look out for it carefully in palliative care. Hopelessness too can be helped with psychology input. For example, cognitive behavioral therapy works with this, but also spiritual help from chaplains or other counselors. But would these things be picked up every time someone asks for assisted dying? Especially when, as we've seen, there isn't enough palliative care or mental health care in the UK to meet people's needs. In Oregon, less than 1% of people get a psychiatric checkup beforehand, before they have assisted suicide. And this risks missing either the depression or the hopelessness, and it could make mental capacity assessments less secure. And it's unlikely, really, the UK would be any better in this regard. And why else is it bad for patients? Well, first off, what happens where it's legal? Well, numbers go up year after year, as you can see in the Netherlands, Belgium, Oregon, and Canada on the slide there. In Belgium and the Netherlands, it's been legal for a long time, but still the numbers are going up. In Canada, assisted dying, which is nearly always euthanasia there, that's direct killing by the healthcare professional, the doctor, it's increasing by more than 30% per year. And already 4%, that's 1 in 25 of all deaths in Canada, are performed by healthcare professionals. In the Netherlands, it's more than 5% in the reports, and in Belgium, they report more than 2.5% of all deaths. But we know that there's significant underreporting in both those countries, so the numbers and proportions will actually be higher. In Oregon, the numbers are a bit lower, but they are going up year on year. And as you'll see, the top figure there is the number of prescriptions that are issued. The bottom number is the number of people who actually die from assisted suicide there. There's a gap between them. We know that a third of prescriptions issued are not used. People change their mind. And the law is often tested. For example, we've seen criminal prosecution for non-voluntary euthanasia of dementia patients in the Netherlands, and the law becomes ever more permissive. You must have heard about Canada. There, it's no longer just for terminal disease anymore. Death no longer even needs to be reasonably foreseeable, as they phrase it. And if you look closely again at these figures from Canada, you'll see the red bits at the top of the two blue columns there. For those 2 years, those figures in red are the percentage of the MAID deaths performed on people who weren't dying. Their death was not reasonably foreseeable, and this is now allowed by Canadian law. They've even legislated recently to allow it for mental health problems as well. It's also already being offered there to the handicapped instead of providing daily living aids or modifying their housing. And this sort of mission creep is happening elsewhere too. Assisted dying is becoming more and more accessible, but help to live a fulfilled life is withheld. And there are other reasons too why it's bad for patients. So we know diagnosis and prognosis are both often inaccurate. Firstly, doctors can get the diagnosis wrong. For example, we know cancers can be missed, as in this story here on this slide about a missed ovarian cancer, the poor lady. But equally worrying, something might be diagnosed as cancer or another serious illness, and it's actually something else. And then prognosis, which is about how long someone has left to live, is never as accurate as people think it is. And in the hospice, we see both extremes of this. People given short weeks to live by their oncologist who are still alive after a year or so. Or people who are told they'll be around next Christmas, which is months away still, who are admitted desperately ill the next day and die a week later. In Oregon, in 2023, we know that there, from official reports, 5%, so that's 1 in 20 of people who had assisted suicide drugs, were still alive 6 months later, even though the law says it's only allowed for those with less than 6 months prognosis, 6 months left to live. They don't get it right there either. And it's that sort of imprecision that causes fear and anxiety and worry and loss of trust among patients and people. And it may be one of the things that's fueling these demands for assisted dying. And there are also lots of problems with the medications themselves, the medications that are used for it. So for assisted suicide, the drugs are taken by mouth. They taste awful. They're difficult to take because huge quantities are needed, and supplies are not guaranteed. The medications are not licensed for killing people. No medications are licensed for that, to kill people. And they're also often used experimentally. Oregon is already on its 8th combination of drugs to see which are the best to kill people with. And all these drugs can cause horrible side effects as well, such as vomiting or seizures. Again, looking at Oregon, because that's what we're trying to, the people who want to begin assisted dying here want to model our model on. In Oregon, these kinds of side effects happen in 10% of assisted suicides. And that's 10% of assisted suicides where the information's available. But worryingly, the information is actually only available for a third of such deaths, because it's only recorded if a health professional is present. And that only happens a third of the time. Most of the time, people die without a doctor or a nurse around. And also, in Oregon, the assisted dying records are destroyed after only 1 year. So looking back is very difficult. And then the drugs may not work. People wake up after taking the medications rather than dying. One Dutch study several of those wanting assisted suicide had to be actually euthanized instead with a lethal injection because the medication didn't work. But for those that do work, the Oregon report again, it tells us that the medications can take 6 days to kill the patient. Where is the dignity in this sort of death? For euthanasia, injected drugs are used. These usually include a sedative, a knockout drug, plus a drug to paralyze the patient. The aim is to sedate, then paralyze, so when unconscious, breathing muscles stop working and the person dies. But if paralysis kicked in first, death could be awful, suffocating, not able to breathe while still aware. And we'd never know. No one is alive to report back what happened. We do know in the UK, anaesthetists tell us that patients can be aware during operations, despite adequate doses of the same medications. So why should this be different? And in fact, our parish priest in Chichester, where I live, was telling us about this just last night. He woke up on the operation table when he was having a hip replacement. And also, we know not all doctors are good guys. Dr. Harold Shipman was Britain's most prolific serial killer. 24 years ago, he was convicted of murdering 15 of his patients, but it's believed he probably killed hundreds of them. It's not clear why he did that. Some were possibly for personal gain, being in their wills and things like that, but not all. It seems he just liked killing people. And not all healthcare is high standard or compassionate. You'll know about the recent scandals, the avoidable deaths in Gosport War Memorial due to excessive doses of painkillers and sedatives, the furore over the Liverpool care pathway about 10 years ago now, the more recent Lucy Letby case, and then we've got the NHS perma crisis we've talked about, and there's always a bed shortage, always pressure from management to clear those beds. And where is that going to lead if we bring in assisted dying? And in Canada now, there's really big concern that assisted dying is killing people on the margins of society. Only last week in Ontario, the government's own assisted dying monitors there reported they had serious concerns about people being euthanized for unmet social need rather than for medical reasons. Another thing that's really important when we start thinking about assisted dying is safeguarding. If it were allowed, assisted dying, how could we be sure things like coercion, elder abuse, and carer fatigue didn't influence those requests? And these are real issues which we as palliative care doctors and GPs in the UK often see, but we often miss them as well. The Oregon 2023 report shows that the assisted dying doctors had only known their patient for an average of 6 weeks before death. So how could they possibly assess properly for these? That's because, like in Oregon, most UK doctors don't want to take part. So the patient's usual doctor isn't involved. It's likely that such safeguarding issues would be missed here in the UK too. This is really dangerous, given, as we've talked about already, 50% of assisted dying requests are because people don't want to be a burden. So what about doctors then? Well, despite efforts by activists, most UK doctors' organisations continue to oppose legalisation. A few are neutral, but none are in favour. And around the world, the American Medical Association and the World Medical Association both remain firmly opposed. Notably, in the UK, the British Medical Association did a survey of its members in 2020, and it found that most doctors in the UK do not want to take part in assisted dying. And moreover, the ones most against it were those doctors who look after dying people, GPs, geriatricians, palliative care doctors like me, oncologists, and most hospital physicians. Those in favour of assisted dying were those who are not involved in patient care, people like histopathologists, X-ray doctors, and public health doctors. The recent PMA Consultants Conference passed a motion that I proposed, in fact, insisting no consultant is expected to take part in any way. And there are good reasons for all this uneasiness among doctors, especially those who care for people at the end of life. Firstly, it goes against the ethos of medicine, which we learn at medical school, and that guides us throughout our careers. It's based on the Hippocratic approach, and that's guided Western medicine for thousands of years now. And that sees doctors as having duties to their patients, to their colleagues, to society generally, with compassion, with respect for the patient's inherent dignity at the forefront. It insists doctors must do no harm, and it specifically prohibits, as you'll see here, if you can read it on the slide, if yours is big enough, it specifically prohibits poisoning our patients. And that clearly excludes assisted suicide and euthanasia. And this original Hippocratic oath has been brought into the modern age by the World Medical Association's Declaration of Geneva, which you'll see there. This was urgently needed in 1948, just after the Second World War, with all its horrors, because of the medical horrors under authoritarian regimes at that time. It was felt the Hippocratic ethos had been overridden and it needed restating. And the Declaration of Geneva requires doctors to maintain the utmost respect for human life. So it steers you away from assisted dying there still. And most UK doctors follow these ideals, and they underpin the General Medical Council's current good medical practice guidelines, for example, which we have to follow. And why else is it bad for doctors? Well, a Canadian palliative care professor who's a friend of mine, she tells me that doctors there are already having to choose different areas of practice or even leave medicine if they don't want to take part. Nova Scotia recently started making it a legal requirement to refer people for it if asked to, and for doctors to have to tell patients that it's actually an option, like all the other possible treatments. You can have assisted dying on the list as well. Many doctors there are going to resign if their consciences are ignored like this. And likewise, it's going to cause moral distress for UK doctors if it's brought in here. I did a survey of staff and volunteers in a UK hospice, and people would resign here too if it were introduced. And this moral harm is not just because doctors see assisted suicide as killing their patients and viewing it therefore as completely wrong. It's also because of the way it will destroy a vital, trusting relationship between doctors and patients. And without that trusting relationship, patients don't get better. If a doctor takes part in assisted dying or even has to suggest it to patients, people are going to feel not only is it acceptable to undergo it, they may even feel duty-bound to undergo it, and that would be intolerable. So what about society more generally? Well, we've seen how the numbers go up where it's legal, and we've seen how eligibility is getting wider in Canada. It's happening elsewhere too. In the Netherlands and Belgium, patients with early stage dementia are euthanized, even though mild dementia sufferers can live for years. And also in the Netherlands, terminally ill children can now be euthanized if the parents want it. Where, tell me, is concern for the child's autonomy there? So in Oregon, they've recently removed the long-standing requirement that you had to be a resident there before you're allowed to have assisted suicide. And also there, the requirement for a terminal illness that will lead to death within 6 months isn't robust. A Freedom of Information request to the Oregon Health Authority has revealed it actually also includes diseases which, if they weren't treated, might lead to death within 6 months. So it could include conditions like diabetes or paracetamol overdose or an abnormal heart rhythm if the patient refuses treatment. They become terminal and they can therefore demand assisted dying. And that might explain why people with diseases not usually considered terminal, such as arthritis or complications of a fall or a hernia or anorexia, have all had assisted dying in Oregon. There truly is a slippery slope in all these places. In fact, you can think of it as a black ski run. People who weren't originally candidates for assisted dying are now included on so-called human rights grounds. Already in UK Parliament, a group of MPs have signed a letter saying they want to widen the bill to include non-terminal diseases. We've also got former MP Matthew Parris, who you might have heard of. He's calling for the legalisation of assisted dying, specifically so the elderly and infirm can be disposed of to conserve resources. So this move towards assisted dying, I think, reflects today's emphasis on identity and so-called neoliberal values at the expense of a fall in notions of collective responsibility and of social justice, which are big parts of Christian social teaching. They seem to be fading away in the face of this move towards the fetishization, if you like, of autonomy. And again, in Oregon's report, it shows that 80% of assisted dying recipients are on what they call Medicare and Medicaid there, not private insurance. And that is over twice, 80% is over twice the proportion in the general population. And those two schemes, Medicare and Medicaid, they're for people on low incomes, the elderly, the disabled. And this worrying year-on-year increase in the less well-off seeking hastened death there must be a warning to us here in the UK. And also in Western countries, there's a really good focus generally on trying to reduce suicide rates. And it had been expected that non-assisted dying suicide rates would decrease if assisted dying were allowed. Indeed, its proponents use that to justify it in some of their arguments. But the research shows the opposite is true. There's a 6% increase, more than 6% increase in background suicide rates where assisted suicide is legal. And that's even greater for older individuals. For them, it's 14.5%. And that fits with what we know about social contagion in suicidal behavior. It spreads. It's clear you don't discourage suicide by assisting it. So before I finish, which won't be long now, a few specific areas that might help. So people have brought them up in earlier meetings. Firstly, motor neurone disease, a dreadful disease, and people are often seen in the media on TV who've got it, arguing quite plaintively for assisted dying to be legalized. And it really is causes nasty progressive disability, it causes fear, it causes dependence on others, and they really are difficult things to deal with. And one argument is that they should be allowed a hastened death to avoid dying of suffocation or choking and to avoid being dependent on others. But this is Peter Scott Morgan. You may have seen this if you're on the internet much. He's a famous robotics and artificial intelligence expert. He had motor neuron disease, and before he died 2 years ago, he was a great campaigner against assisted suicide. And despite being completely paralyzed and being told he had only 6 months left to live, he was inspirational. He said, "My overall quality of life is exceptional. I have love, I have fun, I have hope, I have purpose." How many doctors tell their newly diagnosed motor neuron patients that there's no such hope, he asks. And I've looked after many motor neuron disease patients at the end of their lives, and they can live comfortably with good care and die well. And the deaths are usually peaceful. Choking is extremely rare, both in my experience, but also there's evidence in the medical literature about this. There's a 24-year-long study at St. Christopher's Hospice. Only one patient died choking, and that was back in 1968, soon after they opened, before they had developed the best techniques to look after people. But in another large study across Europe, no one died choking. A great majority died peacefully. And patients, often though, do have a strong fear of a distressing death. That's understandable. But we can help with fear about things without killing the patient. Now, breathlessness is another problem in motor neuron disease and other respiratory and heart diseases, but it too can be made bearable with various techniques, various medications, with oxygen or ventilators if they're going to help the patient. When I first meet severely breathless people who are near the end of life, they're often desperate and panic-stricken because they don't understand what's happening or how near the end of their lives they are. And good communication and trust are vital at that juncture. They always are in palliative medicine, but particularly at that stage. And you need to recognize together with the patient that death is not far off, and that gives the patient permission to adjust their activities and to start making peace with their relatives and peace with people they might have fallen out with, and to pace themselves. It makes them less fearful of taking the powerful medicines that will help their symptoms, and it allows them to make plans for where they want to be cared for, where they want to be when they die, and to clarify what they want to do about going back to hospital again, for example, or having resuscitation. It puts them back in control, and that's so important. Motor neuron disease sufferers also often have pain, and like other terminally ill people with pain, this needs meticulous attention to detail. You need to carefully work out what's causing it, first of all. You may need to combine different groups of painkillers. You may need to explore different routes to give them. But most importantly, any symptom, like pain, will have psychological and social and spiritual elements to it as well. It's what we call total pain in palliative medicine in this country. One author's called it soul pain. And these need to be carefully assessed. And the impact and meaning of the pain for the patient has to be explored. Pain can be controlled, but it takes skill and it takes determination. And most importantly, for all people who are nearing the end of their life, is when they're ready, discussing with them what dying will be like, finding out what their fears about it are and address those. And do that openly, go as fast or slowly as they need to. Explain that as dying gets nearer, they'll be wanting to do less and less and eat and drink less and less. And they'll eventually take to their bed and spend more and more time asleep. And that dying is usually very peaceful, with the breathing slowing, with gaps developing in their breathing, and then quietly stopping. There's very rarely anything unexpected or dramatic that happens. And with this reassurance, they often become a lot calmer very quickly. So I reassure that we can control any symptoms that do come up and that we'll watch out for them. So here in the UK, all this assisted dying talk that's going on in the media, in politics, means we discuss it at work quite a lot, obviously. And recurring themes keep coming up. There's fear, there's anxiety around the effects on our workplace, on the service we offer, and particularly whether we may be expected to participate in it. And I've just been having a fairly heated argument with some of the people in the hospice world why we shouldn't do it. There's fear about change in general. And of course, all of this is made much worse by lack of information and feelings of being ignored. And fear an ideological agenda is going to be imposed on us, whether we want it or not. I hope it won't be. Assisted dying would irrevocably damage the practice of medicine in the UK. It would make the public unsafe, and it would threaten what I think is the fragile but beautiful thing that is good end-of-life care here in the UK. So please, please help make sure it doesn't become legal here. Meet your MPs, write to them, and pray if you're a religious person. A few very final thoughts. Firstly, you don't have to kill the patient. You don't have to kill the patient to get rid of the pain, the breathlessness, the fear of dying, or anything else. You need to listen to them. You need to recognize their personhood and fears and manage their symptoms very carefully. Secondly, a lot of the demand for assisted dying is because people think dying is a terrible time. But with good end-of-life care, people go away with better memories and want a good death like that for themselves. And I think you understand my views about the situation in Canada and Oregon now. So in summary, I hope you see why I think legalization of assisted dying is a bad idea. It would harm patients, it would harm doctors and healthcare workers, and it would harm the public. And I hope you see, on the other hand, good palliative care, properly funded, available to all, is the humane answer to suffering at the end of life. And of course, assisted dying, I think, is morally wrong. So thank you all so much for listening. I hope the emotion and the statistics weren't too bad. We'll take questions after Alethea's spoken to us, and we'll take them together. So if you could just hold the questions for a little bit, but we'll speak to you in a second. Thanks.